With the highest number of people infected with HIV in the world, South Africa is at the epicenter of the global HIV pandemic. Young women account for the highest number of infections, with about 185 contracting the virus every day.
In the adolescent girl and young woman population, that's between ages 15 and 24, we have about 1,300 new HIV infections every week. But that 1,300 is very high. So we need to prevent those infections in these young people, which means we have to work as well with men who are having sexual relations with these young adolescent girls and young women and infecting them.
With close on 8 million people infected with the virus, activists say government has failed to provide an uninterrupted supply of medicine to millions of people on treatment, which has dire consequences.
The national department is willing to roll in more than 2 million people on treatment, as per the presidential announcement during his SONA. With the current drug stockouts and the shortages that we have, I don't see us getting there anytime soon.
So there is a real risk in the future of us developing a problem in South Africa, having drugs, if the drug stockouts translate into community resistance and people start transmitting resistant virus.
HIV/AIDS activists say some HIV-positive patients have abandoned the government's test and treat program because they are unable to access ARVs. This may result in the infection progressing to AIDS. It also poses a greater risk of transmitting the disease to others, greater susceptibility to opportunistic infections, and eventual death.
We are in Tsakane, we are based in Eguruleni. We are dominated with 6 clinics in my area, whereby I used to work with all of them, doing a monitoring of stockouts as part of the duties of treatment action campaign. So the population around Tsakane, I would say we are plus minus 2 million, because we have more of informal settlement.
Does it do functions on weekends and that? This 57-year-old man tested positive for HIV 7 years ago. He wants to remain anonymous because he fears stigmatization and possible victimization. Communicator.
Angazizwa nje ngigula. Ngihamba ngaye esibhedlela, mangiya esibhedlela bangithatha igazi, bangitheka, bangithola ukuthi senginale ukugula lokhu. Ngeke ngabona ukuthi ingathi impilo yami seyizoba yifishana, ngeke ngisaphila ngale ndlela engizophila ngayo ecaleni ngingakatholi ukugula. So ngithe mangithola la maphilisi ngabona ukuthi hayi impilo yami sezawuqhuba, ngoba la ngiyazizwa lokugula bekungiphethe akusabi ngale ndlela bengingakho. Sengiyazizwa ngiphilile.
Sipho is one of more than 4 million South Africans on antiretroviral therapy, which is free at government health facilities. In 2008, the country's antiretroviral program was funded by the United States. Today, however, it is mostly funded by South African taxpayers.
It's a big cost to the South African government, and as you may know, that the South African government is the major funder of our HIV program. In fact, upwards of 90% of the total cost of the HIV program is funded through the central fiscus, which means taxpayers' money, South African taxpayers' money. We have a fairly large contribution from the US government under what's called the PEPFAR program, which we're very grateful for. So the total cost of the program is probably around 30 billion rands, of which 19, almost 20 billion rands, is in the form of a conditional grant, which is controlled from the national department, and then we work with provinces to allocate the funds.
The treatment for HIV is both expensive and complex, as doctors have to ensure patients are tested regularly and receive the proper combination of drugs.
So lime wine we're using in this country at the moment and in most of the world is very safe, relatively cheap, works like a bomb in TB and pregnancy and all sorts of things. The problem with it is it's not very forgiving. If you miss a few tablets, you get resistance, and then you need line 2. Line 2 requires lots of tablets taken twice a day, and it's quite a lot of toxicity and it's very expensive. So we really prefer everybody prefers you to be on line 1. Line 2, and then finally line 3, South Africa is the biggest line 3 project in the world by far, is very effective, but is very expensive and very toxic and difficult to take.
Sipho says he developed resistance to the ARVs he was on. He became increasingly sick, lost a lot of weight, and was prone to opportunistic diseases like TB and pneumonia, which are a main cause of death in HIV patients.
Ngiqale ngathola amaphilisi la ngangiphathi kahle abangigulisa kakhulu. Ngazo ngicabanga ukuthi ngona ngiwayekile ngawaphuza.
He was then put on a different combination of ARV treatment, a cocktail of pills that is meant to suppress the HIV virus in his bloodstream. Just as he was getting better, the nurses at the clinic told him there was a stockout of medication.
Kusho ukuthi 3 months kumele ngithola 3 ngithola abayi-6 kuba yi-3 for 3 months. Container one ina 56 phakathi. So manje njengoba sengiwathola kanjena ngiwathola ngaphelelanga. Angisazizwa kahle emzimbeni wami. Just kuba nokubaba uyikhanyana ngiphathwa nasiyeza. Ukuthi manje amaphilisi wami awasaphelelanga. Just esebenza early 1 kakhulu, early 1 alisekho.
Discovered myself here in Zakane.
Fikile says that throughout the government supply management system, blame for stockouts is being shifted from one department to another.
Based on the information that we get from the clinics, at times they are not sharing, but at times they are saying maybe it's the issue of a depot. Like currently, at first they told us that they've ordered, but the issue is on the issue of a depot. We called the depot, and the depot told us that even us, we don't have the second line regiment. That's how we managed to dig deeper, and because we have a connection in terms of the province to check with the other depots what is happening, other township what is happening, and we asked the facility managers, did you borrow from other clinics? They will share to us that even the next door clinic, they don't have the very same drug.
The National Department of Health's policy is to ensure that people get tested for HIV regularly and if found to be positive are put on treatment as soon as they've undergone counseling. But despite efforts being made by the state to keep the HIV infection rate down, South Africa still has the highest HIV infection rate in the world.
With respect to the HIV epidemic, we estimate that we have around 7.9 million South Africans who are HIV positive. And of those, we have about 4.4 million who are currently receiving antiretroviral treatment. So you can see that the problem is big. So of the 55 million South Africans, about 7.8, 7.9 are HIV positive. And of those, we have just over half on antiretrovirals, which means that we have a fairly significantly large number of people who are still not on treatment but HIV positive.
According to the Department of Health, those most at risk are young women who mainly contract the HIV virus from older men.
In the adolescent girl and young woman population, that's between ages 15 and 24, we have about 1,300 new HIV infections every week. Now that's come down from about 2,000 new infections in the same age group, in the adolescent girls and young women. So between 2014-15 and 2017-18, the numbers have come down, but that 1,300 is very high. So we need to prevent those infections in these young people, which means we have to work as well with men who are having sexual relations with these young adolescent girls and young women and infecting them.
AIDS activist Andrew Musani says the reason for the virus skyrocketing in young girls can largely be attributed to the so-called blesser phenomenon, where older men in relationships with young women don't practice safe sex.
What the guidelines are saying, they mean you should be prepared on the day to be initiated on treatment. If you're ready, you get initiated immediately. If you're not, you need psychological or any assistance that is to prepare your mind.
However, Andrews says the government's test and treat program has been derailed because there is a shortage of medication at facilities.
With the number of people that are on ARVs today and the number of people that are still living with HIV who are not on ARVs, the program is not working for me. The national department is willing to roll in more than 2 million people on treatment as per the presidential announcement during his SONA. With the current drug stockouts and the shortages that we have, I don't see us getting there anytime soon, because we have problems in facilities, especially the PHCs, the primary health care. There are challenges down there in the communities. So by us looking at the test and treat policy in the National Department's Minister's Office, the implementation is going very slow.
Okay, my name is Fikile.
According to Fikile Mutswane, an activist who monitors patients' access to ARVs at clinics in the East Rand, drug shortages sees patients abandoning the program.
So now this is not
It's going to create a high rate of defaulter rate, because by going to the clinic, not getting the treatment, you are going to get tired. And then also in the body of a person, it's going to cause a resistance by not getting it. And then also number 3, I think this thing of this shortage, it's going to create something whereby we lose many people, we lose many lives. As we speak about the defaulter rate, some, they decided to leave the treatment. What's the use of me taking this treatment? Because when I went to the clinic, I could not find it. We are receiving cases whereby a person just decided that I'm tired, I'm not going to take this treatment, because every time when I go to clinic, they say it's out of stock, it's out of stock.
For health practitioners working in government facilities, it creates a huge challenge to ensure HIV patients do not default on their treatment.
What we are seeing consistently, though, is that government doesn't communicate with its healthcare providers, the nurses and doctors on the ground, about these stockouts. And these things are hard. You know, I'm an HIV specialist, and I have difficulty something working out. If I don't have drug X, what do I use instead of it? Do I use drug Y or drug Z? And that's really important to get right.
Support group Stop Stockouts monitors the availability of HIV and other drugs at government facilities nationally. The information is collected by people working in communities, nursing staff, and patients who call in on a hotline to report stockouts of the drugs.
When you are not taking your medication, you end up like going back to that medication, it's not working anymore, meaning that you have to move from that first or second line to another level of the line. And then in that case, there is a process. You don't just go there. They need to do some tests for you to go into second or third line. So it's a very long process, a lengthy process. And then now patients are frustrated. They are angry because they are missing work. They go to the clinics. They don't have money. Other people are not working. So it's a very big challenge that we're experiencing of people calling us complaining about not getting that treatment at clinics.
Late last year, we asked Kopano Klaas of the Stop Stockouts projects which areas in the country are most affected.
What we have here, it's stockouts that have been reported by both patients and healthcare workers. As you can see, we've got the red there, it means there is danger there. So it meaning that those provinces are severely affected, like it's Eastern Cape, that as well as Mpumalanga, those provinces are very, very severely affected. So what is happening is that whereby there are few stockouts, the color is blue, but whereby there are most stockouts, it will be orange, and then where there are most stockouts would be red.
We asked him to give us the bigger picture of drugs stockouts in the Gauteng province and surrounding areas to find out what the situation is like in Sipo's area.
This is the Gauteng area. Currently, we're sitting at that number of stockouts that are reported.
That number 54, what does that represent?
The data that is here, it's all the ARVs which has been reported to be out of stock. It's 54 clinics.
Okay, so in the Gauteng province, 54 clinics are in dire shortage of ARVs.
Yes.
Activists say last year they warned government 6 months before they knew there was going to be ARVs stockouts, but they failed to respond or put any contingency measures in place to avert a crisis.
The department was alarmed about this coming stockouts 6 months ago. What led to this is that the national department and the minister, they didn't respond quickly to the outcry of the suppliers and the pharmaceutical companies.
We wanted to know from the National Health Department why were HIV patients not getting their medication. The department's Dr. Jürgen Pillay says they've had challenges to ensure an uninterrupted supply.
If local manufacturers can't order the API, they can't manufacture the drug, which means that there will be a shortage. And we call that a supplier-driven shortage. So that's one example of a shortage. The second shortage is where the depot, because we have these depots all over the country, if they don't order the drug from the pharmaceutical manufacturer, then it doesn't exist in the depot. Then if the facility doesn't order the drug in time from the depot, then the depot doesn't send the drug to the pharmacy in the facility. So you can see that there are API manufacturers who are outside the country. There are manufacturers of the tablets in the country. There's the depot, and then there's the facility. All of this must work before the patient can get the drug in an uninterrupted manner.
He says even when they do have the drugs in stock, there are serious lapses in the government's supply chain management systems, which often prevents the pills from getting to the patients.
We can't afford to have any disruptions in the entire supply chain. And that's why it's very important at facility level, the facility staff and the managers to ensure that they do their quantifications properly, which means they must know how many patients they've got, how many patients will come in today for their medication, how many will come in this week, how many this month, so that they can project how much they should order from the depot. The depot must do exactly the same thing. In the whole country, we've got about 4,000 clinics. So we've got to know every day how many of every drug that we need in clinics, how many drugs are going to be issued, how many are in the facility, how many are in the depot, and what the suppliers have. So it's a massive supply chain that needs to be actively managed.
At clinics, healthcare workers have their work cut out for them, not knowing what to tell patients when they experience ARV stockouts.
The nurse on the ground doesn't know. So what we're seeing is that the nurse on the ground will run out of a drug. She'll get no guidance as to what to do in the meantime. She also won't be told when the stockout is over.
South Africa has come a long way from what experts call the AIDS denialism of former President Thabo Mbeki's administration. The then Health Minister Dr. Mantu Chabalala Msimang controversially advocated for the use of beetroot, garlic, lemons, and olive oil to treat HIV infections, adding that traditional medicine could also be used.
I think it is important for us to also understand that it is not just antiretrovirals. We've got traditional medicine that we know actually averts the AIDS-related diseases. And one of it comes from here, from the Northwest. We are busy studying it with the Medical Research Council of South Africa, and we are seeing excellent results.
According to reports, 2 independent studies estimated that the country experienced more than 330,000 preventable deaths due to the delay in making antiretroviral therapy available to HIV positive.
We had to fight about the cause of AIDS, about the cost. There was just every single victory was a running battle. It's been so much easier to win that on a scientific basis. The battle we need to win now is the supply lines. I don't think there's any different. I think within government, there's no problem with winning the scientific debate. What we're not winning at the moment is the service delivery debate.
We appreciate that our people understood and accepted that what reparations were dispersed.
Despite what experts say was the overwhelming evidence of how the state's intransigence affected the country, Mbeki reiterated his position in his 2016 open letter on the issue. He wrote that a virus cannot cause a syndrome, which led to widespread condemnation from HIV activists, civil society, doctors, and scientists.
So if you're on antiretrovirals, the virus disappears from your bloodstream. Your immune system gets better, your state, your physical state, everything about you gets better. You also don't transmit the virus. You don't transmit it to your sexual partners. You don't transmit it to your baby. Through breast milk. You don't transmit it to the fetus when the baby isn't born yet. All those good things happen. When you take the drugs away, that disappears. So then the virus comes back. It's able to transmit to the baby, to your sexual partners. It also starts doing damage again to the immune system. Makes you more vulnerable to TB, pneumonia, all the bad things that we're trying to stop. And on a more psychological perspective, it really undermines the adherence message to that person. It's very, very scary to have your life dependent on this tablet, and then the people who are responsible for making sure that tablet gets to you can't seem to be doing their job.
As recently as last week, Sipho says his life is on hold because he still hasn't received his full supply of medication.
Hayi ngizotha ubuhlungu kakhulu kangakuba ngiyabona ukuthi manje ngathi impilo yami sezoba yifishane. Angeke isaba ngale ndlela ngicabanga ukuthi izaba ngakhona ngoba bese ngisitshela manje ukuthi njengoba ngiphuza la maphilisi shothi mhlawumbe ngenzeka ngiphile uma 20 years or about 30 years.
Stockouts of ARVs threaten to reverse the gains that have been made in the country's response to HIV/AIDS. Sipho and millions of others in a similar situation only rely on the state to ensure that they receive the life-saving drugs.